In our last episode, we talked about how an eye injury registry has helped researchers to understand how eye injuries happen to create prevention strategies. We explained that there are two main types of eye injuries: open or closed injuries. As a reminder, an open injury is when the eye wall has a full thickness wound. For example, a penetrating injury with a sharp object. In this episode, I will chat with Dr. Jackie Tan, who will tell us about his project on a new surgical technique to close wound in the cornea without stitches. I am Maria Cabrera Aguas, a researcher at the University of Sydney Safe Sight Institute. Welcome to the Sydney Eye Podcast. Please consider subscribing to our podcast to receive a notification when a new episode is released. You can find us on Spotify, Apple Podcast, Google Podcast, Stitcher, and on YouTube. Full-thickness corneal wounds occur with routine cataract surgeries, corneal transplantations, or penetrating injuries. Some complications of a corneal wound are leakage of the anterior chamber fluid, resulting in low pressure and deformation of the eye. In addition, ocular surface contaminants can enter the eye's internal sterile environment, potentially causing an infection in the interior of the eye with risk of losing the sight and even the eyeball. Our guest today is Dr. Jackie Tan. He's a general practitioner based in Adelaide, with a passion for vision research and ophthalmology. Currently, Jack is undertaking his PhD under the supervision of Professor Stephanie Watson, who is the head of the Corneal Research Group at the University of Sydney Safe Sight Institute. He is going to share with us part of his project on testing a new technique to close wounds in the cornea without stitches. Hi Jack, thanks so much for joining us in our show today.
Pleasure.
Jack, I've known you for some years now and heard that your project is about a new technique to close corneal wounds without stitches. Can you tell us how this technique works?
Yeah, so it all stems from the fact that cornea sutures are, highly skill dependent. You take years to learn and to perfect it, and they still snaps. They cause a lot of troubles. I mean, I suppose we've been using cornea sutures for so long, we know how well it works and how poorly it works. So we want to have a new technology to circumvent this difficulty we have in the clinical field. And so we investigated this technology, which not my I didn't invent it. I'm not that smart, but one of our bright spark professors came up with this technology, and I was very proud to be part of the team to investigate this technique to overcome sutures in corneal surgery. So that's my research in a nutshell.
Okay, and when did you start working on this technique? How many years ago? Oh.
Makes me feel like a dinosaur. I think I started in 2015, so I'm probably year 6, part-time of course, so I'm still doing a bit of work, clinical work, while I work on this PhD.
Wow, it has been some time. Can you walk me and the listeners through the technique?
Yeah, so I think we should go back to, if I can, I'll just take the listeners back to basic sciences and how this technology works. My disclaimer, we haven't used this technology on humans yet, but we use it on several different models. Obviously, hopefully we'll move into humans eventually. So how this technology works, it primarily is made of a polysaccharide called chitosan. So chitosan is a repeating monomers of sugar. So other examples of polysaccharides include starch, glycogen, and cellulose, the cell wall. So essentially it's a biocompatible molecule. So essentially you're making all these sugar molecules join together to form a rigid structure. So that's chitosan in the really, really basic form. With advancements in material science, this chitosan can be made into a film. And this film can be very, very thinly made, almost like contact lens. You know how contact lens can stick onto the cornea surface? So this technology is a bit like that. So it's a tiny little thin chitosan film that can stick onto the cornea surface. Now, chitosan in its own has got this hydrostatic attraction to collagen. So it naturally sticks to collagen already. but we can enhance the stickiness of this cartridge onto the cornea collagen by laser irradiation. So that's how, in a nutshell, in a basic science, how this technology works. So we make a very, very thin film that sticks onto the cornea with laser activation.
Sounds like a very quick procedure.
Yes. So very, very quick. So far, we have experimented on 8mm circular patch. So we got a hole around this 8mm in diameter, and we'd also tried a oval patch 4x6mm, so oval shaped patch. We have a laser footprint of about 1mm diameter. So the laser beam that we use to so-called color or shade the patch, that laser beam's got a footprint of about 1 mil. So we just got to move it around the patch until the whole patch is covered. And that varies in between 45 seconds to about a minute. So very quick. So considering each cornea suture can take you a few minutes. I mean, for me, I'm a novice surgeon. Stephanie could, my supervisor could do it much quicker. Takes me about 2-3 minutes at a minimum, one suture. Whereas the patch, I just put it on, laser it. Before I know it, they're done. So it's very quick. I mean, this technique can even be enhanced because at the moment our laser footprint is 1 mil. But if the laser footprint can be designed to be bigger, essentially you can just put a patch on, zoop, and then you're done. You can be that quick because if you can make the beam bigger, this whole thing is covered in one hit.
Well, indeed, it is much quicker than doing some stitches in the cornea. After you laser the patch, what is the next step? Do you need to place a bandage, contact lens, or anything to protect the eye?
At the moment, we are seeing very, very strong adhesion onto cornea surfaces to a point that it's almost difficult to peel it off, if you want to call it. But it also depends on the native anatomical environment where this patch is deployed. For example, when we did this technology on a enucleated eye, essentially this eye has got no more eyelids left. When we put a patch on, we don't have to do anything, we just leave it there. However, with the eyes with an eyelid, we find that sometimes the eyelid can sometimes push the film off because of the sweeping effect of the eyelids, and sometimes a bandage contact lens could be helpful. So I think we may need to use a contact lens just to see how things go. If things goes well, we may say, look, we may not even need it. Ideally, we don't need it, but we may start with one.
And then what happens with the patch? Is it reabsorbed?
Yeah, so it's biodegradable, but it's quite slow in biodegradation. So I mean, I didn't do the breakdown experiments, but previous researchers has characterized the degradation of these cartridge films in lysozymes. Lysozymes are found in your tears, and that breaks down the cartridge slowly. So it's a fine balance between how quickly you want the film to dissolve and how long you want the film to stay on for healing. So trying to find a balance can sometimes be quite challenging. And the beauty of this patch is that it's also semi-transparent. It's got a slight tinge, but you can see through it if you really look hard through it. So you can see whether the wound underneath the patch is healed before you peel it off.
Okay.
So at the moment, we are seeing weeks before the patch shows any signs of structural degradation. So it's strong enough to last for weeks, but you can peel off anytime you want, if that makes sense.
More on this new technology for closing corneal wounds up next. But first, have you had any complication from a cataract surgery, corneal transplantation, or penetrating eye injury? Tell us your story and email us at seedeyepodcast@gmail.com or share on Twitter with the hashtag SeedEyePod. That's hashtag SYDEYEPOD. Yep. Okay, perfect. So in theory, what would be the advantages of this technique compared to the stitches or to the other traditional techniques?
Yeah. So lots of advantage. Sutures, because you have to use a needle to pull onto tissue and penetrate tissue to bring tissue together, you can cause damage to the surrounding tissue. Because sutures applies point-to-point tension on a cornea, the pull can cause unequal tensions and cause warpages on the surface of the eye. And we call that surgical induced astigmatism. And that's very, very difficult to correct even with glasses. Now, because these sutures are foreign materials, they could be nylon or silk, they can create a foreign body reaction to the patient. Then we also have cyanoacrylate glue. Essentially, these are your medical grade super glues. They are not technically supposed to be used in the cornea, but a lot of ophthalmologists are using them off-label for savoring the eye, because when you cannot get anything else, that's like a backup plan, if you want to call it. Now, cyanoacrylate are not biodegradable, so they are essentially acrylic, essentially plastic. They are inflammatory because the breakdown product will cause inflammation on the surface of the eye. Now, cyanoacrylate seals very quickly. It's pretty much instant. Like, if you have done any arts and craft and you accidentally touch super glue and your finger just, that's how
it's
quickly
really
it sticks.
uncomfortable in your fingers.
Yeah, so that's how it works. So essentially we're using the glue on the surface of the eye and it sticks so quickly, which is good. It seals quickly, but trying to apply it accurately can be a challenge, because trying to be very precise with those glue can be a challenge. So combined with the rough surface, inflammatory side effects, and non-biodegradable, cyanoacrylate obviously is not really approved for ophthalmic use, but only used as a worst case scenario, like a backup plan. So that's cyanoacrylate. Then we also got the fibrin glue, which is also quite popular. It's been around for 50 odd years. Fibrin glue is essentially biocompatible and biodegradable. Very well tolerated by most patients. It's not uncomfortable, but there's a risk of bloodborne virus transmission, because fibrin glue is derived from blood bank. So it depends on what the donor has. They obviously was trying to screen the donors, but there's some infection that doesn't get tested or cannot be tested, and there's always a risk of reactivation when you use that. So that's your traditional technique. So the advantage is that this technology that I'm working on has over these guys that because most of the glue we've seen so far are liquid based, so they have to draw it up, put the liquid onto the wound and wait for it to set. Ours is completely different. We've got a patch, so it's like a band-aid that you can just stick onto the eye, and you can trigger the stickiness when you're ready. So essentially, you can put this patch on the eye, adjust it until this is a perfect orientation I want this patch to be, and then you put your laser on and you stick it on. So it gives the operator a lot of control over the adhesion property of our technology. And also, some of the glue, after you put the components on, you got to wait about half a minute, sometimes a few minutes to wait for it to set, especially fibrin glue. Ours, once you put the laser on, it's stuck on straight away. And because our is a patch, the size can be adjusted. So if you've got a small wound, you can have a small patch. You've got a bigger wound, you can make a bigger patch. You've got a star-shaped wound, you can make a bigger patch to cover the star. And this has not yet been tested, but if you have a cornea graft, which is circular big disc, we can even make a little round ring that go around the wound, and that can work. So I think the combination is endless. So that is one of the benefits that we've got.
For sure, this technique is very innovative and tackles several complications from the current corneal wound treatments. Is there any limitation in the size of the wound?
We're hoping that this technology will have unlimited wound size consideration, but because this is only early stages of our characterization, we haven't made the wound really, really big. As a starting point, we are only targeting smaller cornea incisions now. So those small ones that we often see in cataract surgery, they're usually between 2 and 3 mils. That's perfect target for what we're hoping to use it on. So if that makes sense. I would say we have endless possibilities, but we're only starting small. Yeah.
Okay. All right. So how far are you and your team to take this technique to the operation room?
Tomorrow. I wish it's tomorrow.
Because I understand there is a long process. You have to do different clinical trials, and then so how would be your forecast if everything goes?
I'm very thankful for the predecessor researchers that have been and gone before me. They've done so much work. So previous researchers has done in vitro characterization. So in vitro characterization means they are testing this material in a test tube, making sure it doesn't damage the cells that's been collected from the cornea. So far, their result has been excellent. And then we move on to the cornea. We've done lots of tensile strength testing. This is also not done by myself, but previous researchers. They've done tensile strength testing to see how much strength it takes to split the cornea bits. So when it comes to my turn, I'm actually testing the technology in an intact eye, an intact cornea. So we're using burst pressure now instead of pulling the wound apart. So essentially what I'm doing now is injecting water or fluid, if you want to call it, increases pressure in the eye until the eye pops where we did a cut and sealed with the patch. So that's how I'm assessing the integrity at this point. So that's what we call ex vivo testing. So to answer the question, when are we going to get to humans? I hope soon, but there are some consideration with human ethics committees to see whether if our investigations are sound and worth moving on to a human model.
Before we get to the end of this exciting talk, are there any complications from this technique?
Yes, now with all new technology and new medications, there's always going to be potential risk. So let me just take the listeners to a few events unexpected events that happened during the course of our study. So we found that, yes, we laser the patch with a handheld lasers slowly, but if we accidentally left the laser on one spot for too long, it actually burns the patch. Now, whether or not it causes any cornea damage, we're not sure. Because once it's charred, we move it away, and it hasn't really caused, because the experiment that we did it on a radial eye, so they're not live eyes anymore. So we don't know whether we're scarring down the track. But the very important thing is when you're operating the laser, you have to be very, very careful. Now, there's also a theoretical risk because chitosan is derived from crustacean shells and sometimes from shellfish. So there is that theoretical possibility of a patient with seafood allergy. They may not be able to have this technology put on their eyes, because
wow.
what if they react to the seafood patch, so-called, on their cornea?
Oh, wow. Okay.
Yeah, but we do know that the cornea is avascular. There's limited blood supply, but in inflammatory conditions, sometimes there are blood vessels coursing onto the cornea. Whether or not it can cause an allergy reaction, we are not sure, because not yet tested on humans. It's a theoretical risk at the moment.
Oh wow, it's a
long road indeed. Yeah.
Yeah, but hopefully we can get it very soon into humans.
Yes.
Okay, so if people want to contact you, Jack, what would be the best way to do it? What would be your social media or email? Or
yeah, I'm supposed to be young, but I'm not very good with social media. So I would say best way would be go to SafeSight. We have a corneal research group. Leave me a message there, or I think my Twitter. I think it's a Dr. Jack 10. I think.
Okay, that's okay. We can add it into the notes.
Sorry, Maria. Not very good with social media, but yeah, I would say SafeSight. Go to SafeSight and maybe Cornea Research Group. My name should be there, and I think there's a link to my email as well.
All right, perfect, Jack. No, thank you so much for sharing the project with us today. So we'll keep in touch to see the further advances in this technique.
Thank you, Maria. See you, everyone.
Right. Bye-bye.
Okay, bye.
In summary, this technology uses a patch which sticks very strongly to the cornea upon laser activation, sealing full thickness corneal wounds up to 6 millimeters in size. Possible applications of this technology include closing leaking, penetrating corneal wounds after routine cataract surgeries, closing traumatic corneal lacerations from battlefield injuries, and replacing sutures during corneal transplantations. I am Maria Cabrera Aguas. Thanks for joining us on the Sydney Eye Podcast. If you haven't yet subscribed to this podcast, you are invited to consider that to receive a notification when a new episode is released. If you have any questions, comments, or suggestions, please send them to seedeyepodcast@gmail.com and connect with us on Twitter at Cabrera Marie. It's CABRERAMARIE, or at Cornell Research using the hashtag SYDEYEPOD. Until next time, bye!